When Dhaval asked me to talk on the bone loss, I thought this will be an interesting case so that because every now and then we keep showing a lot of cases. So I thought this is the latest one I did. So I'll take on to this. He is one of the doctor who was from West Bengal. So he 34-year-old. He came to us with a progressive deformity of distal femur with a sinus discharge from the proximal third leg. So it was like you can see that it's like a floating knee injury. And then in fact, his original injury was like this. So actually it was a shattered distal femur. And then it was a good reconstruction that they did. So you can see that they have done the plate fixation, looks a good reconstruction. And then he also had a nailing done for that. But overall, there was some 4.5 centimeter of shortening, is as expected in this type of combination. So this patient the accident was in July 2020, and then when he came over here in 21 July, nearly 1 year later he came. And then at that stage, you can see that patient's complaint was like it is progressively getting deformed into a varus position. But when he came in, so the distal femur did not have any redness or no local rise of temperature. ESR and CRP were within almost like a normal limits. But only thing was the sinus discharge was there. So it was a purulent discharge near the proximal tibia. So it was from the tibial side. So what I did was I didn't want to go and end up doing something for the femur with purulent discharge. So first is to clean it up, and then I removed the implant on the tibia side, debrided the sinus, and then closed it primarily. And then at that stage, what I thought was like, depending upon the culture report, we will go ahead to do the next stage. So when we took the culture, again, it was a negative report. You all know that in a long-standing purulent discharges, almost always you get like, because antibiotics was given for a long time, you will end up having a no growth as the result. Similarly, that's what has happened. So once it was done, and then in 1 week time, it was relatively all right. So what this is the movement he had at that stage. You can see the mild varus deformity patient was having, and this was the major complaint for him. So as a doctor, he was continuously looking at the knee joint, and then he was complaining that he's always worrying. And then he had an unphysiological gait indicating that it was definite non-union at that stage. So after a week, then we planned for a femur revision. So to go ahead to do a femur revision, so what was the base? I was having multiple options. Like anyway, like it was, my first impression was that it will be like a regular non-union revision. It was like a bone grafting and getting it aligned and then putting it a plate. But when I went in, you can see that each of the screw hole tip, you can see there was a pus or purulent material on that area. And then you can see that the distal end of the proximal fragment was completely avascular. So this was a surprise at that stage. So when in fact, I didn't even counsel the patient for this beforehand. So I thought we will be doing a non-union surgery, but at the end of it, what we had to do was to completely remove all those avascular segment, and then also like all the infected material, everything, we curated it out. And then when we curated, this is the bone loss that we ended up with. So I didn't do any external fixator at this stage. I thought initially in my mind during surgery, I thought I will keep the external fixator so that the length can be maintained. But however, because we did a good debridement, we have removed all the non-viable tissues. It was like almost like a radical debridement that we did. I thought it should be go on, and then within few days to 1 week time, I thought I will go back in after a period of 1 week of antibiotic, and then I will go ahead to do the fixation. So this is the post-op. And then when I measured intraoperatively, see that is the scale that I have kept it to measure. It was a 7 centimeter bone gap. So this is the post-op X-ray that I have got. And then is there any prescribed guidelines for this type of situation? I couldn't read in a literature. I didn't find any literature saying that if this is the situation, what could be done. And then I suppose if there was frank infection that we had, and then if it grows an organism, everybody says You have to give an antibiotic for 6 weeks and put them on external fixator and wait and watch. Later, you can go on to do this. So now I have a situation where ESR CRP is normal. Clinically, there is no problem. And then only as an intraoperative surprise, and then with a good debridement, I thought I can go ahead within a 1 week time. So after 1 week of antibiotics, I planned for getting because see, like if it is just a allograft or something that I'm putting, then it is a problem purely because having a situation that is suspected infection and then allograft or something, it can get infected. That is one idea. So when we have a microvascular, here it can, because of the vascularity and with antibiotics, it can actually resist some sort of infection. So that was the whole idea. And then I went ahead to do fixation first. I got a good traction and then got a nice distraction and then put a plate. And then once the plate was applied on the laterally, I can see that we got the intraoperatively, the cable wire test was done. So that one, we know that the hip center, knee center, and then the ankle center would be all right, correctly aligned, because patient came with the symptom of progressive deformity. So I didn't want to have any deformity at this stage. So got it correctly centered. And once it is centered, then I had to go on the opened on the medial side. So with the plastic colleague's help, then we did a vascular fibula. We just shove it into the distal femoral condyle, and also proximally I made a trough on the femur and then put a plate on the proximal side. Because we put into the condyle distally, it was stable enough. Proximally, I had to fix it on the medial side with a good anastomosis of the vessel. So this is the post-op picture. And then you can see that one, it is in 3 months. You can see that it is all getting okay. And then you can see that when we did the alignment cord after post-operatively, it was perfectly aligned. There was no problem. But the shortening is somewhere around 3 centimeter. What was 4.5 centimeter? Now it is a 3 centimeter shortening. And this was at 3 months, we had this amount of movement, and slowly it was improving. And this is at 5 months, he has this X-ray. And today I asked him to send the pictures. Today he sent the pictures. His movement has completely improved. He is walking, gone back to activities, and he is also, his gait also has become completely better. So this is so we have a good success story in this. So the only point I wanted to bring in was, suppose if somebody has got this intraoperative surprises and you end up having such a big bone loss, what will be doing it? So that's why I thought a vascular fibula in this scenario may be a good option instead of just an allograft. Otherwise, you just have to fix and hope for just pack a lot of suppose, for example, you can also use, we have done few of the titanium mesh we have taken on the medial side and kept it along with the iliac crest grafts. And that also has worked in few individuals. So these are the methods by which we can do it. Thank you.